a manner as to promote your honor and glory and to advance the peace, prosperity, and welfare of our county and of those whose interest you have committed to our charge. Honorable members and the Secretariat, together with our nominee, welcome to today's session. This is a committee on appointments, and it is established pursuant to Standing Order 187 of the Nandi County Assembly Standing Orders. I believe with us is nominee for health and sanitation, that is Dr. Angeline Chepchirchir.
That's true.
Okay. The clerk, you can administer oath to the nominee.
I, Dr. Angeline Chepchirchir, do swear that information I shall give before this committee on the matters under its consideration shall be the truth, the whole truth, nothing but the truth. So help me God.
Welcome again, Dr. Angeline Chepchirchir. As initially alluded, this is the Committee on Appointments, together with the Secretariat, and I'll take this opportunity to introduce the members of this committee, together with that of the Secretariat. Myself, I'm the chairperson, and Cheriot Mel is my name. Majority Leader, we can have the members of the committee introduce themselves immediately on my far right, immediate right.
Thank you. I'm Honorable Walter Teno, MCA Kabiet, and also Leader of Majority, Nandi County.
Good morning, Dr. Angeline. I'm CPA Paul Bidech. I'm member of Appointment Committee. Thank you.
On my immediate left, and as you introduce yourself, you can declare any conflict of interest, if any.
Thank you, Chair. Kirongo Eliud is my name. Also member of this committee, and the leader of minority. No conflict of interest, Chair.
Okay, I'm Sarah Mutual, member of this committee. I have no interest.
My name is Martin, a member of this committee. No interest at all.
The Deputy Clerk, you can introduce yourself and the team.
Good morning.
Good morning.
I'm CS Isabella Mayo, Deputy Clerk, Legislative.
My name is Dorothy Chipto, Secretary to this committee.
My name is Moses Keme, part of
And I think we have our sergeant standing over there. So welcome again to this committee. I've indicated before that this is a committee on appointments that is established pursuant to Standing Order 187, and its mandate is to assess the suitability for the position for which you've been nominated to serve, as provided for under Article 179 of the Constitution. You're going to engage with the committee members for 60 minutes or thereabout. But before that, we wish to notify you that this committee is not adversarial in any way, and therefore, they'll be asking you questions, and we expect those questions to be very concise. And you'll be asking questions. We'll be asking questions through the chair, and we also expect you to respond to those questions through the chair. So before we give you that opportunity, we will wish to know whether you have your original documents.
I do.
Kindly hand over them to the clerk for the purposes of verification. And that includes the ID card or the passport, your resume, and also the clearance forms, that is from DCI, Higher Education Loans Board, the Credit Reference Bureau, and also the Ethics and Anti-Corruption Commission.
Yes.
Okay, thank you. So as we verify, Dr. Angeline, we're granting you 10 minutes just to tell us about yourself before we make progress.
Thank you, Chairman. I am a married woman with 4 children. I was born in Jeptonon Village, Chepchirchir Ward, Nandi North District. I schooled early schooling in Jeptonon Primary School. That's the nursery before primary level. Primary, I went to Kapkanyaloi Primary School, public school. Proceeded to Chepchirchir Girls, St. Joseph's High School, Chepchirchir for all levels. Thereafter, went to University of Nairobi for a bachelor's degree in nursing. After which, I proceeded for internship, 1-year internship, which is mandatory before licensure for practice by Nursing Council of Kenya. I did it in Kenyatta National Hospital. Thereafter, I got employed by Moi Teaching and Referral Hospital, where I worked for 4 years. And upon which I went back to University of Nairobi in 2004 for postgraduate studies. I took up a master's degree there, and then I was employed as a tutorial fellow, then subsequently promoted to lecturer, and currently I hold the position of senior lecturer. It's about 20 years later. Besides being an academic with daily roles involving teaching and supervision of students, I also do clinical care. And besides academic work and mentorship, I also have some leadership, professional leadership roles. I am a director at Chuna Sacco, which is the cooperative society that takes care of the financial needs of the University of Nairobi staff. I'm also a trustee, the University of Nairobi, WASU chapter. That's university. WASU is University Academic Staff Union. I'm also a treasurer for our National Housing Court Residents Association. That's where we live in Nairobi. And the Residents Association takes care of the welfare of the residents within the courts. A position I've held for the last 3 years. So beside that also, I've taken up roles in the church and as a secretary of our St. Jude Irish Catholic Church, and also chair of the small Christian community, St. Clair, and currently I'm an active member of St. James, which is a small Christian community in our Langata residence. I also am a co-founder of Eco Changers Initiative. Eco Changers is a CBO. The CBO that creates awareness among children between 5 and 13 years about environmental conservation. So what we do is sensitize the children in churches, in schools, just about the awareness, you see, in the wake up of climate change, how they can take care of their small environments, ensuring that they put off lights, reduce, heating spaces unnecessarily, and so forth. That is what the rallying call of the CBO is: my environment, my responsibility. Besides that, I've worked in a number of committees at the university level. For the 20 years I've been there. Gender mainstreaming, when it was a new concept in our country, disability mainstreaming, ensuring inclusivity, even in handling student affairs. I'm currently the student patron at our Department of Nursing Sciences. And also supports Kenyatta National Hospital in research mentorship, clinical research mentorship. So I work as a facilitator at the Department of Research at Kenyatta National Hospital. So we support clinical staff to write proposals, implement them, and also write papers, publications. I wish to stop there.
That's a very wide sphere of life. And what then makes you think that you're suitable for this particular job that you've been nominated for?
Thank you, Chair. One is my professional qualifications. When I look at them and the expectations and the requirements of the office, that gives me a strong belief that I am the right candidate for that office. So one, being a health professional, having both clinical and academic experiences, which are important in understanding the issues around healthcare. My level of literacy when it comes to technology, and which is one of the vehicles that is being adopted to improve service delivery today. So I believe that level of understanding would give me an impetus to be able to serve and also bring change and try to support the delivery of health services in the county. Additionally, my exposure, having worked in Kenyatta, worked in Moi Teaching and Referral Hospital, currently as a staff at the University of Nairobi, with also clinical roles at Kenyatta National Hospital, and working with the Nairobi County primary healthcare facilities where we train our students. I have the current exposure on the challenges that we face as a nation. And I believe the challenges faced by the Nairobi residents in terms of access to health is not so different from what is happening here at home. And I'm also a resident of this county, and I know in my neighboring healthcare facilities, I know what is hailing the service delivery. My exposure outside the country, I have had about 4 months stay in the US, in Seattle, and I've been able to compare and see what aspects of service delivery do we, maybe we are yet to streamline really our own to be able to attain that effective service delivery. So that exposure also would help me in the roles of CEC in charge of health and sanitation to borrow from what has or is happening elsewhere and be able to help and see whether there can be an improvement in service delivery here at home. And of course, undertaking research. Evidence-based approaches are the best always in decision making. So those highlights makes me believe I'm the right candidate for the position. Thank you.
Thank you for that. And you realize that if given an opportunity to serve as the CCM member in charge of health and sanitation, you won't work in isolation. You'll comprise the county executive committee. What do you think that, what new ideas will you bring to the county executive committee?
Okay, so of course working in a team, teamwork is very key. No one person can work in isolation. So one is to understand in a collaborative manner how the systems have been working. And being a new person in a new place, it is possible to have that, ability to see something different that can be done differently from what the incumbents or the people who have been in that space have been doing. So I believe my knowledge, skills, and exposure, I can use it in a positive way to collaboratively influence one or two strategies that are being adopted currently. Thank you.
Thank you. I now want to hand you over to the other members of the committee so that you can have an engagement with them, starting with my immediate left, Honorable Kirongo.
Thank you, Chair. Good morning.
Good morning.
Daktari. I have 2 questions for you, and then my question number 1. Records before this House indicate that there are significant delays in the distribution of medical health facilities throughout the county. We have the Act, which F5 Act 2022, which was actually anticipated to address this issue. However, it has not achieved its goal. What is your actually priority will you make to ensure that this issue is being addressed? My question number 2 is, drugs are a crucial commodity in our health facilities. However, there are constant lack of drugs in our health facility, despite constant allocation of the budget. Now, you can tell us probably why is it so? And then, again, a number of cases have been reported. Once the drug is applied in our facilities, it disappears. Now, what mechanism do you have to ensure that we have the safety of drugs? Thank you.
Thank you, Honorable Kirongo. So one thing is that the Facility Improvement Financing Act was meant to improve efficiency, actually at the facility level. And that is why the provisions were given that resources collected within the facility can be appropriated to take care of the immediate needs. However, if that is not happening, then the question is why? And the first thing I would want to do is to understand the provisions of that act as they are, and what is the shift on the ground. Is it the management? Is it the administration? Is it bureaucracies? What is it? Because as at now, I may not give that answer because I'm yet to be an insider. I am yet to get the powers to examine. And with examination, so I would wish to do an evaluation of what it is not. And then from there, we'll be able to align and improve on the utilization of these resources. So one is the money collected? Who receives the money? How is that money used? Because there has to be some traces of how the money is used. And if the challenge is the money goes to the pool, the large account, and it disappears, how else can we ring fence that money so that it's always available for use, so that it doesn't get lost into other needs of the county? Because I know the needs are more than the resources. So that is my response to F5, because it is a very good vehicle if utilized well, because there are facilities that have used it very well, and they are able to run. As they await their allocations from the county central treasury, they are able to meet one or two things. So my promise is, one, to do an immediate evaluation and examine, get to know where the problem is. And with the help of the assembly, the health committee, they will help me to whether to revise the regulations or the policy guiding the utilization of the funds here so that we make it effective. The second question about the resources, the commodities, and the drugs. There is usually a question, we always assume that resources always delay. But it means that if they delay, even when they come, these commodities should be available. So that is very clear. Commodities were just missing for 2 weeks because there was a delay. But when they come, they are available. But the challenge here is, even when they come, they are not there. So where are the resources? Where are they going? So one thing I know is from previous discussion with the CEO, I noted that the system that we are using to monitor these drugs and commodities does not have a feedback loop. So we are not able to see where did the commodities go. We can actually trace they came, yes, they are in the inventory. But when it comes to release, dispensation, we are not able to follow the logs to the end. Hence, we can't account for. So basically, we need accountability. So what it requires is strengthening the supervisory role of those in charge so that they take a responsibility, and also putting in the systems, leveraging on ICT so that we can track where these commodities go. Thank you.
Fair enough, Chair.
Honorable Martin.
Thank you, Chair. Good morning, Dr.
Good morning, Honorable. Good morning.
Dr. I think we are blessed as a county because I remember actually when we were vetting the former immediate CEC, I mean, she actually had the same credentials just like you. Because I remember also when actually she was telling us about her credentials, she also mentioned having been in the US for quite some time. And you are here again, hoping for the best. My question is to guarantee, how can we, to guarantee health services to the people of this county, bearing in mind that our facilities in terms of dispensaries are not workable on weekends. What is your take about that? And then again, second question is about the ambulances. What policy would you actually put in place to make sure that the efficiency of these ambulances in time of need can be accessed to as quick as possible in order to save lives, if need be? Thank you.
Thank you, Honorable. For the first question, the design of service delivery in dispensaries for the longest time has been that most of them are closed over the weekends. But then there was this informal and written rule that at least one health care provider should be within the facility in terms of residing within the facility, that they can be called upon whenever there's an emergency and they attend to the emergency. So one thing I would wish to reiterate is, one is to understand where are these facilities, the dispensaries, the distribution. The service providers, do they reside around the facility? Number two, how many staff are in that facility? Because one challenge has been, you only have 2 nurses. They can't cover the weekend because one has to be off. And if one has to work at night, so there's a challenge with the staffing, because if you do not have the staff, you're not able to organize the duties to cover, including the weekends. So one thing is having them within reach, if it's possible to have accommodation facilities, at least a housing unit for at least 1 staff to be within the vicinity of the facility. They can attend to emergencies. Number 2, employ additional staff so that they can cover all the hours or the shifts that are possible in those facilities. And that comes back to the legislation, the rules and guidelines on how do we manage the primary healthcare facilities in our county. So that is something that also needs discussion, because it has an implication on resources. If you talk about staffing, we have to look at the resources. Otherwise, there are enough, potential employees that can take up the responsibilities, but then the resources on what can we manage and what can't we take up. There are maternity units that in dispensaries that have maternity units. They are always open 24 hours, at least because of the maternity units. So they run throughout, even the weekends. We also have dispensaries that are probably run by missions hospitals, or private partners like mission hospitals, or the tea farms, organizations. We need to leverage on their corporate social responsibility if they can help us to ensure that these dispensaries run throughout. So that requires discussion of the public, creation of public-private partnership. How do we engage them so that they help us, even by sponsoring maybe an additional staff on contract or something of the sort. So I believe that can help us to operationalize those facilities. The issue of ambulances. The ambulance service has many components. We have the vehicles, and we have the human resource, and we also the logistics required to run. So the vehicles need to be in good condition. The human resource needs to be well versed with their roles so that they can attend to emergencies, and they should also have the right attitudes to act as expected. And then logistics has to do with ensuring that the vehicles are in good condition. There is fuel, they are, mechanically correct so that they can move, and ensure that the emergency is evacuated, or the casualties or the emergencies attended to. So in this regard, in this county, we have understood that we have about 8 centers or locations for the ambulances. But what needs improvement is the coordination. So coordination, probably by now leveraging on technology to ensure that we are able to know which ambulance is where and what is it doing, and ensuring that we don't reallocate other tasks, using our ambulance vehicles other than the designated task, which is evacuation. Thank you.
Just a follow-up on that, we also note that there are maternity wards that are domiciled in these dispensaries, which currently are complete and equipped but are not operational. If approved, how will you mobilize personnel to operationalize the said facilities?
Thank you, Chair. I would straight away work in collaboration or liaise with the Human Resource Department, especially the Director of Health Planning and Administration, because that is the focal point where I will get the understanding of how many or how extensive is our human resource, or how limited is our human resource, and whether we have areas where we can borrow and redistribute the human resource to ensure that those facilities run in the, as soon as it is possible. There's also need to probably, if we do not have the ability to redistribute the human resource that is already existing, we might have to have targeted recruitment just to get the 1, 2, 3 staff needed to run those maternity units, because it is not in order to have them closed, yet the citizens are awaiting the services. Thank you.
Mr. Chair, just a final question, a
Yes.
general question.
Proceed.
Dr. I'm pleased with your vast knowledge and the experience that you have. Just a general question, because the reason why, I believe that the reason why you are applying for this job is actually to take this county to the next level in terms of health services. Supposing it get to a point whereby you have the rich ideas, but you are not capable due to some unavoidable circumstances. You are not, you can't be able to expedite your rich ideas. What do you think?
Thank you. I'm one of those people who do not give up. I will stay on, because I believe if I will not be able to make 100% a difference as I expect, I will do something small, and even that enlighten, or making the people you're working with understand how best, even if it's not adopted at that point, it is shared. And I believe human beings, they might refuse today, you might refuse tomorrow, but the third day, you'll still get a concession. Thank you.
Honorable Kirongo, you seem to be having a follow-up question.
Yes, just one question that I noted I forgot on issue of hygiene in our facilities. What do you consider to be the most effective approach to the managing the cleanliness of our first personnel and then to our facilities? What actually terms of engagement do you think you believe it is the most effective for ensuring high standards of cleanliness? Thank you.
Thank you for the question. So, looking at what has happened in the past, most government institutions really have gone for professional cleaners because they will do their job as prescribed. If you look at the opportunity cost, you might look at initially that you're paying slightly higher, but that higher fee ensures the quality that you desire. Because the challenge of handling cleanliness and hygiene internally means when we do not have the resources, the challenges with FIF funds and all that, then it means hygiene issues stall, and that is really a greater risk. So the best is to outsource a cleaning company because they take responsibility, and management is external. You really do not have issues. And that is what has happened. Our cleaning companies are.
Thank you, Chair.
Honorable Sarah.
Okay, thank you, Chair. Okay, to my sister, Dr. Angeline. Okay, feel welcome. So with me, I will just take you with a general questions. So my first question is that we have only one referral hospital in our county. And having only one referral hospital, there's a lot of congestion in that hospital. We also have the outpatients coming to the same facility. So if given, okay, this chance to serve as a CC, how best will you handle the patients who are being referred and the outpatients, people who are just from around visiting the hospital? Because mostly we have witnessed that there is a lot of challenges, especially when there is emergency. We have people coming in as outpatient, so at times some are left out, and then the doctors or the staff there are rushing in one end, the other end remains without a staff to serve them. So when given this opportunity, how best will you manage emergencies in our referral hospital?
Thank you, Sarah, Honorable Sarah. I agree with you 100%. And if, as a citizen, if I am living within the Kapsabet municipality, even if there is another neighboring facility at my doorstep, which is a health center, even if I had some, slight fever, I would still want to be seen in the referral facility. And because we always perceive that there's quality there, there's efficiency, an improved service delivery setup. So then what does it mean? It is us now to ensure that the referral facilities are more effective as that referral facility when it comes to our patient services. That way, many people would be able to utilize services in the facilities outside the referral facility. And how do we push the clients, the citizens, to utilize the level 1, level 2, level 3 facilities, level 4 facilities? We have to put in policies that if you're coming to the referral facility, you come in with a referral letter. A referral letter from the referral facility, is what will give you access to the services at the referral facility. That way now, we push the people to make use of the services within their vicinities. Because even if you go to that health center, if you really deserve to be seen in the referral facility, they'll give you a letter and you come. But we reduce the self-referrals, the walk-ins, because the walk-ins are the ones now who increase the number. And then it masks the ability of the staff there to attend to the critical cases. So that needs a discussion with the health management team at the referral facility, and then you gradually introduce that. You let the citizens know, by this time we will be implementing this, and we would wish people to do this. But we also must strengthen the quality of service delivery in level 4, level 3 facilities. Thank you.
So another question is that we all believe that prevention is better than cure. So back in the villages, we have the CHBs, and there's also the public health. But you find that the residents or the villagers, they have not realized actually what the CHB is doing, and even the public health sector. So when given this chance, how will you bring together the public health and the CHBs, those whom we have? Because these are the group who can easily assist or train or teach people on how to prevent some other diseases.
Thank you. I know we have the district public health nurses, and their work is largely in the community. Apart from monitoring vaccine distribution, family planning commodities, their work is also to ensure sensitization of the citizens on disease prevention, promotion of self-care initiatives through health education. So one thing that needs to happen is we need to increase the awareness, because as you put it, the citizens may not even be aware of the roles of the CHPs. And the CHPs on their own may not be able to sell themselves. They cannot advocate that we are the people who are going to serve you. So there is need for another voice to enlighten the citizens on the benefits of utilizing the CHP services in terms of health education. And that means the district public health nurses in the sub-counties and the designated areas, they must be able to map out the areas. They know which CHPs are where, whether they have the programs for health education, when are they doing community dialogues, are they visiting schools. And that way, if it is happening in every other sub-county, every other ward, then we increase awareness, sensitization. And then I believe CHPs are equipped to some extent based on their expected roles. And if the citizens makes use of them, then we would be able to improve on identification of those with chronic diseases, the hypertension, diabetes, cancer, before they are too late in time. So my role would be to strengthen the sensitization, both for the CHPs and also ensuring that they are able to deliver health education in the communities. So that falls on the public health nurses. So I would work with the public health nurses teams to ensure that they strengthen their roles in the respective areas of jurisdiction.
Okay, to continue is that we have these common diseases that affect our people, and it is killing them, especially cancer. We even have the HIV, which is spreading very fast. And also we have these respiratory diseases, especially to the women. Most women nowadays are being attacked by these respiratory problems. So, and I've seen that even our county is silent on it. And even this cancer campaign is very low. And HIV. So given this chance, anyway, how would you carry out your campaigns against such diseases? And then another question is that, the number of children born with disabilities or disorders, the number is increasing, especially those ones which are being attacked by mental disorders. And you can see that all this, with the proper management, when the mothers are expectant, it can be prevented. But still, a lot of campaigns or teaching has not been done, and the number is increasing. You can go to a village and you can get even up to 10 in one village that mental disorders or whatever that came up during that during pregnancies or during birth. So this is something which is increasing. And again, handling these people who have got severe disabilities is a problem also. We find that most of them come from the most vulnerable families. So to handle them is a problem. We find that they are even having problem languishing in poverty. At the same time, they are not getting this medical assistance and so on. So if you are given this chance, how best can you reach to these minorities, the small group? I think it is not the percentage is increasing, but they feel that they are neglected.
Okay, thank you, Honorable Sarah. You've raised very important issues. Maybe I handle the first one on the increasing respiratory disease among women. So I would think maybe women are affected mostly because probably the cooking, the sources of energy that they use in cooking, if most of them are using sources that have pollutants, you see, like the charcoal, smoke, the wood smokes, and the way the houses are constructed, really they don't have proper aeration. So this increases the risk of women being, attacked by most of the respiratory diseases, because what smoke does is it suppresses the immune, mechanisms, and increases the susceptibility of acquiring these infections. Then it means also, because women are the majority who attend our health facilities, as they seek for maternal child health services, we need to strengthen our health education on prevention and promotion of self-health. Because we talk about household health. If the mother is well, the family is likely to be well too. So we increase that teaching through the maternal child health facility points. We sensitize mothers on the need for proper aeration. If they're using charcoal, the way the kitchens are constructed should give room for proper aeration to reduce the risk of inhalation of smoke and the soot in smoke. Now, there's also the aspect of mental health you've mentioned, and some of the causes are preventable. If we are able to handle our mothers in time for deliveries, then we reduce some of the complications like cerebral palsy, children who, if a child to be born delays in second stage, they are likely to have mental challenges. So that also comes in. In maternal child health facilities, through health education, the planning for births for mothers, we can be able to prevent a few of those cases coming up. We also need to sensitize mothers to bring forth their children who seem to be having mental disabilities early in time, because we know stigma also plays a role in suppressing them from exposing their children for care. So we also need to carry on sensitization through the maternal child health facilities and in any other forum that is available in the community, even including the chiefs barassas. The CHPs is a real vehicle that reaches out to every household in our society. And that is why government has given a lot of focus on CHPs. So what we need to do ourselves is map out, do we have enough CHPs? What do they do from time to time? Do we have their reports? Because they are the champions who will be able to reach out to the community members who may not come out even to facilities for care. And if we have CHPs who are well fast with what they're supposed to do, they are able to communicate to the community, then that enlightenment will play a greater role in improving the understanding in the community on mental health issues and the need to seek for care where possible. Now, for those with disabilities, it is still the same community health promoters. They go to households. The households, you can never know they have a child who is disabled or living with disabilities. It is only the CHP who knows that family better. And they can persuade them to let the child, be attended to. And we also need to assess the level of disability. Not with those with mild disabilities can be rehabilitated. And maybe one thing I would use my position, I don't know, is there a way of lobbying for resources and maybe purchase a few mobile gadgets to support those who are not able to move so that they can go to school or they can move out of their houses, they can be rehabilitated. So that would help in bringing out the issue instead of suppressing it. If it's brought out, we will know the burden and we'll be able to handle. And lastly is research, enabling the community health promoters to collect data so that with the data they bring forth, you are able to know how big is the problem and what are the best strategies. They can also give the strategies because they understand the communities better. Thank you.
So the last question, Daktari. We know women can multitask, but from your talk and what I've seen in your documents, you have a huge responsibility in various places. So when given this chance to serve in this county as a CEC, how will you now balance everything? Because county will need you 24 hours. And we don't want you to lose all other activities that you have been carrying out. So how will you balance it, Daktari?
Thank you, Honorable Sarah. The first thing is, if I take up this opportunity, I will dedicate most of my time, especially at the beginning, 100% or 101%, to ensure that I understand the issues on the ground, collaboratively with the other teams, work to ensure that we have systems that can improve service delivery. And that requires 100% of time or more. So that means I would have to seek leave of absence from my current employment so that I concentrate on the work. Of course, the others are not tenure related roles. You see, the one of being a trustee, being a director, they are not full-time, and they are not, full-time employments that you need to have 100% time. So that is my commitment. That's my commitment, especially at the beginning, because I also have to learn and be able to understand the issues. And I would have to be on the ground, to be able to know what is happening. And one of the gaps maybe that usually enables, or brings about challenges in service delivery is when the supervision role is missing or is not strong. Then things would easily go. Thank you.
To the chair.
Honorable Majority.
Thank you, Honorable Chair. Good morning, Dr. Angeline.
Good morning.
Okay, mine is to ask one question because when you are doing introduction, you said you have a vast knowledge in terms of technology, or literacy of technology. So my question is, what are some of the strategies which will you use to so that you can we can have our health centers and dispensaries being actually having issues of ICT, because you find that sometimes our dispensaries doesn't have any issue of technology. That's my first question. Number two, there are some of the incidents whereby there is sabotage on the issue of full automation in hospitals. You find that some of the staff sabotage the issue of automation.
Okay.
Because of the reason we don't understand. How will you address such issues so that we can find all the dispensaries, the hospitals being automated? That's my second question.
Okay.
Thank you.
Okay. Technology helps to integrate systems in service delivery, meaning at a central point you can be able to observe what is happening in various areas with related services. The example I give is in every hospital today, you'll find that they're using a health information system. So you can see this patient came in at this time, was seen by the doctor, picked the drugs, left for home, came back again when, So you're able to trace the movements of a client. It would be nice if we have a similar arrangement in our county, especially the county referral, and also the level force, and subsequently, to the lower levels. Because it will help you to even trace where this person first sought for care and what was done at that point. And it reduces the repetitions in terms of tests that are done repeatedly. A test is done in the dispensary, it's repeated in the health center, repeated in level 4, repeated in the referral hospital. And you're using, the resources in the same area, It is all resources from the county and by extension from the exchequer. So my approach to this is with the support of the executive and the health committee, if we are able to procure an integrated system that we start and implement at the referral facility, then move to the level 4s, the sub-counties, then move to level 3s, and subsequently level 2. It will make our work easier. It can cost a little more at the beginning, but eventually the benefits are more. And it will even be cost effective because you can even monitor, and talk about a patient who is coming from where and going where. The integrated system helps us in capturing real-time data. If we need data now, sometimes you may not be able to get it until you ask, from places so that you can collect. But if you have an integrated system, it gives you data that actually makes you make decisions, enables you to make decisions in real time. So my approach to that is having an integrated healthcare system. Yeah, for the entire county. And that integrated healthcare system should have a loop, a feedback loop, because that is what is missing. Even if there's something, there is no feedback. You wouldn't know whether that client exited, referred, did they get the right treatment? And that one brings gaps, the communication, the trail is not complete. Now, when it comes to sabotage for automation, Honorable, I don't know why this is coming up, but if somebody is assigned a role, like you're the ICT manager and you're supposed to implement, you have your functions in the lab, you're doing your work, another person in the pharmacy. The best would is to know why is the pharmacy point not working? Why is the system failing at the lab level? Why is the system failing at this other point? So that speaks to a different problem, because it's not the system that is failing, isn't it? So someone is failing and refusing to work. So that person who refuses to work, I think there are ways of handling the person who has decided not to work. Yes, thank you.
Honorable Birech.
Thank you very much, Chair. Once again, good morning, Daktari.
Good morning. Thank you.
I have some few questions for you. Recently, we had some doctor strike, and I think actually you watched, and it was a serious one. And I know it actually hinders service delivery. Now, outline your approach on how you are going to improve working conditions and compensation for medical staff to reduce actually the likelihoods of such strikes, because at times agreements are not adhered to. How different are you? What kind of strategies do you have so that any kind of such strikes could not happen in future, or the agreements are actually adhered to? That's the first question. Number two, what strategies would you propose to ensure that medical professionals who benefit from government-funded scholarship do not exceed the county government for greener pastures? Because we have had a number of professionals exiting the service because of such things that are not adhered to. So, how are you going to do it if given an opportunity to serve as the CEC in charge of health and sanitation? Thank you.
Thank you, Honorable Birech. Okay, that's not an easy question though. Issues of remuneration, as we know, even if you paid someone today 100% of what they want, they would still want something else tomorrow. So the issues of agitation for salaries would forever continue as long as, people would always want something different. Yeah, so it will come. What needs to happen is the ability to discuss in an honest manner, and if a CBA is agreed upon, the timeline set should actually be adhered to, if possible. And if not, there has to be a communication as to why it's not happening. The biggest challenge has been that we have national government-sponsored staff, and then you have county-sponsored or county-employed staff. And most of the CBAs are handled at the national level. So really, at the national level, you are at the mercy. Those employees, they listen to their unionists who are handling the problem or the concerns at the national level. So ours is to persuade them. If our work environment here is accommodative for them, because as much as the national CBA is being discussed, if they are able to still continue working with us, if our environment is suitable for them, then they can still offer the service delivery. In a manner we usually call it a cost law. They cannot leave and vacate the facilities 100% that you're having no one. So this requires persuasion and discussion in an understanding manner. Number two, not everything required by these health workers is financial. Is there a way we can do non-financial benefits? Where you maybe improving their work schedules, because they would be able to see that although there's a pressing need, but at least their work environment is more accommodative. So that comes also with the number of staff that we have. Because as it is, the work schedules are more pressing sometimes to the medical staff, that really they are, when a chance of a strike comes, they use it as an opportunity to go on leave. They are not really fighting for the CBA, but it's an opportunity for them to be on leave. So it goes back, how are the work environments for our staff? Are we giving them some leeways, which are non-monetary, so that they are comfortable or somehow comfortable, not necessarily increasing their emoluments? The other thing is the CBA should be structured in advance. So if it is every 4 years, every 3 years, then unionists want to see that the management is also proactive in their interest. If they were expecting a CBA to be tabled in June, and you know 3 months in advance you're not able to give any concessions, write to them that we think we might not be able to discuss. Can you give us time? But if you also request for time, please honor it. So it all boils down to discussions, persuasions, and I believe because they are our own, you know, nobody's coming from anywhere different, we can still be able to improve on that relationship. Thank you.
Unless you still have another question.
Actually, on a follow-up question, Chair, on technology. Daktari, if you visit our dispensaries or stores that actually we keep drugs, we are using the ledger cards, purely manual. Now, because that's an outdated method of actually keeping records, because it's supposed to be a computerized system. But even here at our referral, it's basically the cards that we are using. When you are dispensing of the medicines, still you are dispensing of probably manually, and you are supposed to be computerized. What kind of an idea, or what do you think in terms of policy making do you have? And which type of system would you actually recommend? Because the other systems you have been having that's been failing, that's been sabotage, that's been alluded by my colleague. What kind of an idea do you really have that you think it will really help this county in terms of management of drugs? Because at times you can have sufficient drugs, but when it reaches to the dispensary level, actually it becomes something else. Two, in terms of disbursements, when we receive drugs, for example, from KEMSA, which method are you going to use? Are you going to disperse first to sub-county level? Or what are you going to make sure that each and every dispensary receives drugs as they are requested for in terms of distribution? Thank you.
Thank you. Maybe I would want to start with the last question. The drugs and commodities distributed to the facilities. The best I understand is we should distribute them based on the requisitions. Because one facility in Tindrait might not need certain drugs that are needed by a facility in Chepchirchir. And if we do just the random distribution, you might have excess of a drug elsewhere and missing in another facility. And because of that lack of online systems that can show Chepchirchir still has several of these antibiotic, which is needed in Metete, and it's, if we had an online system, you can be able to say, Chepchirchir, release the excess you have and let it come, to this other facility. That would be the benefit of an online system. But since we do not have, so the first thing is distribute the drugs based on the requisitions, because that is what is needed in that facility, that is going to serve the interests of the citizens accessing care in that facility. That would be the first one. And procurement of these drugs and commodities, the requisitions should come from the facilities themselves, so that we can have estimates. And then we know how frequent should we redistribute them. And there should be revisions over time. There are seasons where you have high malaria cases, there are seasons when you have low malaria cases. So I think that should be a continuous variation, requisitions being specified. And that should be a continuous monitoring thing. It will only be possible if we have an online system. Yes. Now, it connects with your first question of which system is useful. I cannot say this system, because the system I know is used by Nairobi County. Nairobi County is a different their needs and their dynamics are totally different. What usually happens is you get a consultant ICT and you tell them what are your needs, what do you want done, and they tailor make a system for your needs that suits you, because you cannot pick an all sell. You see, even the system that is used in our supermarkets here, what one supermarket uses is a modification of, because it has to suit your needs. So that is my approach, yeah, that we can get a specified system done for our needs here. Thank you.
Thank you, honorable members. The very last question to our nominee. We have the aspect of universal health coverage. We all understand that there is that shift, rather movement from the NHIF to the current SHA. Will you please say something about that? I know that the public is watching, and more so the electors from Nandi, and probably your role in terms of their registration into this universal health coverage.
Thank you, Chair. So universal health coverage, from the word universal, means, broad-based. You're able to access the services as you desire. That's the essence of universal: accessible, acceptable, available, and all that. And because of that, the government set up the intervention before us today with the SHA that we all need to register as members because of the need to benefit in the provision of resources that is going to support access to healthcare. So SHA provides the premiums, the resources that are needed to deliver healthcare services. How does it do? It ensures that people pay up, subscription. Government also puts in some resources. You can have grants, you can have gifts, donations into the same kitty. Now, what is our role as executive in the county and even the legislature? We are consumers of the same services, is to promote registration so that everybody is a member. The same way we were members and registered with NHIF, it gives you some protection or cover to ensure that when you're sick, you are able to access the services. And we know that SHA created the fund, which is the Social Health Insurance Fund. And that fund, from the pool of resources, either from subscriptions, from grants and all that, we are able to draw the resources to pay for services at the primary healthcare facilities, level 1 to 3, and also the social health insurance that takes care of level 4, level 5, level 6 care. And also the people who have chronic illnesses. Many people deplete their financial and economic resources in their own families when they are seeking for care for chronic diseases like diabetes, cancer, renal diseases. So with this SHA, the authority and the fund, it will also ensure that when you exhaust what had been provided for, and this is the difference with what NHIF used to do. NHIF would cover you to where you exhaust your resources, now you're left alone. You would have to look for other alternatives. But these resources now are available because you're not left alone. Then the chronic, the emergency chronic and critical illness fund will take care of that. So what we need to do is to ensure that awareness is done among our citizens so that they understand. If they understand, then they'll see the benefit of registering and subscribing to this insurance. Thank you.
Well, thank you for that engagement. And I think before we bring this session to a closure, probably you can have 2 minutes to make your closing remarks.
So, Mine is to thank the panel for this opportunity, and also to thank the nominating authority, the executive, for giving me a chance to present myself today before you. And so I'm also seeking and wishing for collaborative environment, if successful in this endeavor, to ensure that health service delivery is improved in our county. And I would also urge our citizens to take up the opportunities that have been provided by government through SHA. And also self-care. The responsibility of health begins with a person. Preventing risks that can expose you to severe diseases, including HIV, the alcoholism that we know about, drug abuse. And we be our brothers keepers. If we see someone with a mental health disease, help them early before they complicate and we are not able to help them. Thank you so much.
Thank you so much for that engagement. But just before you leave, I also realized that you do not have a copy of your CRB clearance certificate. Probably you can make arrangements and submit to the Secretariat. And just before you leave, there is this aspect of whether you've been dismissed or rather removed from the office in contravention of Article 75 of the Constitution. I know that is a closed-ended question. It is either yes or no.
No.
Thank you. So at this juncture, you are discharged. But before you leave, ensure that you have your originals, certificates, and documents that you came with. Thank you.